Quickly review what we went over last week. So the contrast agent that we use in MRI is what? Gadolinium. What's our atomic number for gadolinium? 64. How many unpaired electrons do we have? 7. So make sure you know all these for the test. These 7 unpaired electrons interact with the tissue lattice. Remember, the tissue lattice has those hydrogen protons, which is protium, which is the isotope we use in MRI. These unpaired electrons cause water to slow down its tumbling rate. And anytime we are slowing down the tumbling rate, it's getting closer to our precessional frequency. And as we get closer and closer to our precessional frequency of our hydrogen protons, our tissue relax a little bit quicker. So gadolinium is a slightly attractive metal to our static magnetic field. So as it slows down the tumbling rate of water, it causes our tissues to relax a little bit faster. So you can see here as before contrast, if we had a tumor, our relaxation curve is here. But then once we inject the gadolinium, it shifts our curve over to the left, causing that pathology to appear brighter because the tissue relaxes faster, and then you'll have more longitudinal magnetization for our next RF pulse. That is usually why gadolinium is considered a T1 agent, because we get hyper-intense structures post-contrast. Gadolinium also shortens our T2 time, but it's not considered a T2 agent because our T2 curve shifts over to the left, and it causes those structures to appear darker or hypo-intense on a T2 weighted image. So when we're thinking gadolinium, think your T1 curve. Our T1 curve is also called T1 recovery or spin lattice. Our T2 curve is called T2 decay or spin. Gadolinium is very toxic in the body in its natural state, so we need to chelate or bind it to a ligand to make it safe for in vivo, which means inside the body. Our gadolinium is excreted through the kidneys, so that's why it's so important to make sure you test the kidney function of your patient. And what is the main lab value that you're really interested in with kidney function? EGFR. You get your estimated glomerular filtration rate by factoring in your serum creatinine, the race, the ethnicity, and the age of the patient. You usually plug it into a formula. You can find that EGFR formula just by typing it into Google. What is a concerning EGFR?
Below 30.
Below 30. Equal or below 30. So if you're right at 30, that would be concerning too. So if it's 29, definitely something you need to bring to the radiologist's attention, but also if it is exactly 30, you need to bring it to the radiologist's attention. Even if you get close to that number, I would consult a radiologist. But typically, a normal, healthy kidneys are above 60. The range is 90 to 125. I put down here the other lab tests that you're interested in the ranges. And depending on the literature, the ranges vary. So the serum creatinine for the website or the literature that I used, it was 0.6 to 1.5, but I've seen it 0.6 to like 1.2. And then the BUN is 8 to 20, and I have seen 8 to like 25. So on the test, I'll give you the range. I won't give you like 8 to 20 and 8 to 25, and you have to decide between the two. No, I'll give like something that's way off. Okay? The gadolinium chelates that we use can either be macrocyclic or linear. Linear being a more open structure, almost like a straight line, compared to macrocyclic, which is cage-like and surrounds that gadolinium ion. So which one's more stable? Macrocyclic. It usually has less dissociation inside the body because those binds are a lot stronger and it's harder for that gadolinium to be released inside the tissue. The main pathology that was associated with gadolinium, and especially in patients with severe renal insufficiency, was our NSF. And what does NSF stand for?
Nephrogenic systemic fibrosis.
Okay, nephrogenic systemic fibrosis. So dealing with the kidneys, it's systemic, so it's basically the entire system can be affected by it, and then fibrosis. So it's basically hardening of the tissues. And most of the time it was seen in the skin. That's why it's hard for patients to bend at the joints. But it can affect other major vital organs like the heart and the lungs. And imagine if those tissues harden, they're not going to be able to function properly. And that could lead to death. So there have been cases of death associated with NSF. But since they found the link between renal insufficiency, injection of gadolinium, and NSF, they have restricted some of those linear agents that were associated with it, and they really haven't had any cases of NSF since. So it's on us to make sure we are checking our patient's renal function, we're using the appropriate gadolinium-based contrast agent, and we're recording these things in their chart. All right, so we're going to finish up our lecture finishing on gadolinium safety and then talking about each gadolinium contrast agent and then the uses of gadolinium for each particular area of the body. So when we're talking about gadolinium safety, sometimes we talk about our biological half-life, and usually the biological half-life is less than 2 hours. So once you inject the gadolinium, you've eliminated half of that gadolinium within 2 hours. But if you have impaired renal function, that half-life is going to increase. So it has almost increased from 2 hours to a whole day. So anytime you're retaining that gadolinium within the tissues, it's more likely to disassociate from those bonds. That bond that is holding that gadolinium and making sure it's safe with the chelate bonding to the ligand, if it's being retained within the body, there's more likelihood of that bond breaking. So you can see here as you have impaired renal function, the time is extended, and there's more disassociation associated with that. So the stability of the bind is very important. And there's two main properties when it comes to stability of the bind. That's thermodynamic stability and kinetic stability. Thermodynamic stability is dealing with disassociation in certain pH body types. And then kinetic stability is dealing with this half-life. How quickly can we eliminate it? And it's usually, the units are within our time units.
Can you repeat what you said, thermodynamic stability?
Yeah, I'll repeat it in a later slide. So we have a couple of deaths associated with gadolinium, and they were really linked to NSF. But since we've made, the ACR has made the recommendations to not use certain linear agents, these cases have been eliminated. We do still get some side effects when we inject our patients with gadolinium. The side effects could be mild headaches, nausea, vomiting, hypotension, rash, hives, things like that. Those are usually non-systemic. So all you have to do is, tell them to stop by the CVS, get some anti-inflammatory agents. There are really no absolute contraindications. There are recommendations to be cautious of. So some conditions that warrant caution are pregnancy and lactating mothers. So if you give a lactating mother gadolinium, usually you want them to pump and dump for 36 to 48 hours so that that contrast is not given to the newborn baby. Blood disorders like sickle cell anemia, any respiratory disorders like asthma, any previous allergies. So these are things to be cautious of. All right. So here is a breakdown of all the different gadolinium-based contrast agents. So make sure you know the structure of each of these. So know whether it's linear or macrocyclic. Then it gives you a little bit more information off to the side. So Magnavis was approved in 1988 for clinical use. This is the oldest agent. And you can see here an increased risk of NSF. So this is one of those linear agents that was associated with NSF. So the ACR has recommended not using those, especially for patients with EGFR below 30. Multihance, this is a linear ionic agent. This has the highest relaxivity. So do you remember when we talked about relaxivity? Relaxivity is when we are shifting this curve over to the left. High relaxivity agents are able to shift this curve over more, compared to low relaxivity agents won't be able to shift this curve over as much. So Multihance has the highest relaxivity amongst the gadolinium-based contrast agents. So when you inject it, a lesion will appear brighter than if you inject it with Omniscan with the same amount of dose. Let's look at the two agents that we use here at Emory, Prohance and Dotarim. You can see here Prohance is macrocyclic and it's non-ionic. So very stable. It says below average relaxivity. So the radiologists weren't as happy with the switch from Multihance to Prohance because our lesions didn't appear as bright. So it's harder for them to distinguish pathology. But it's a more stable agent, so we're really concerned with patient safety. So that's why we made the move. And then Dotarim, macrocyclic and ionic, which is the most stable chemical structure of any of these gadolinium-based contrast agents. So when you combine those two, you get the most stable, and this has been least associated with any type of reaction. So if you had a patient that has reacted to gadolinium in the past, you want to use Dotarim. Okay? Even if they've had like a hypersensitivity to iodine, just to be cautious, you might want to use Dotarim. Eovis, this is a liver agent, so it's designed for liver imaging. So it's being excreted not only by the kidneys, but by the biliary system. So you excrete through the kidneys, but you also excrete through the liver, which goes into the gallbladder and excreted through the biliary tree. And then you have all the different properties, and you can see their values here. So this column here is our thermodynamic stability. So it's basically the stability of the ligand within blood serum, which has a pH of 7.4. So going back to thermodynamic stability. So thermodynamic stability is the stability of the ligand within the blood human serum, which has a stability of has a pH of 7.4. Your kinetic stability is over here, the elimination half-life. So how quickly are we eliminating half of the gadolinium from the body? So thermodynamic stability, kinetic stability. Those are the two major stability properties talking about the dissociation of the ligand. So you can see here, when we're talking about kinetic stability and elimination of half-life, the smaller amount of time, least amount of time is the safest. So Eovist, eliminate very fast. Dotarim eliminates within an hour, almost an hour and a half. Prohance, hour and a half. Your thermodynamic stability, Dotarim has the highest, Prohance has the second highest. So you can see here why we chose those particular agents, because they're very stable inside the body. But then you go over to relaxivity, and they don't perform as well as some of the other agents. And you can see Multihance has a value of 6.3, so it has the highest relaxivity. Here's the generic, another chart with the generic name of the contrast agent, the brand name, because if you read some of the literature, most of the time they're going to give you the generic name. So if you need a chart to kind of quickly associate it with the brand name, most people know them by the brand name. And then it gives you the chemical structure and ionic versus non-ionic. And then this is what the organic chemistry of the molecule looks like. So you can see here the macrocyclic agents completely surround the gadolinium. That's why it's harder for it to disassociate. Macrocyclic ionic agents are the strongest in terms of stability. And then the linear non-ionic are the weakest in terms of stability. And you can see here these linear agents or ligands do not completely wrap around the gadolinium. So they're open. So there's always a little bit of a hole within the organic chemistry of the structure that makes it more susceptible. Alright, so current applications of gadolinium. So we'll talk about all the different uses of gadolinium. So gadolinium in clinic became available in the early 90s. That first agent was 1988, first used. They help highlight lesions because there's a breakdown in the blood-brain barrier. So anytime you have a lesion within the brain or anywhere in the neurological system, there's a breakdown in the blood-brain barrier, which surrounds the brain and surrounds the spinal cord. So if you have a breakdown, that's when the contrast can leak in and highlight those structures. Okay. Some structures naturally highlight post-contrast, like the pituitary gland, the choroid plexus. There's no pathology usually associated with that, but those structures, but they still highlight post-contrast. Because those structures are highly vascular. So in the pituitary gland, when we covered the brain, if there was a small microadenoma, the microadenoma actually didn't light up with contrast as quickly as the gland did. So the gland lit up with contrast, and that tiny little tumor actually stayed dark until a little bit later. But that was how the radiologist was able to distinguish if there was a tiny microadenoma within the pituitary gland. So some structures do light up post-contrast, and that's normal. So we evaluate mainly the brain, the spine, the neuro system, but we know we use contrast for the chest, the abdomen, and even MSK if there's a lesion or infection within the MSK structures. So just a reminder, contrast agents cannot cross an intact blood-brain barrier, but it does have the ability to cross a breakdown. And when they cross that breakdown, they enhance post-gadolinium. Here are the structures on the left that normally enhance post-contrast. So make sure you know this particular slide very well. So I've talked about a couple of these already. The choroid plexus within the ventricles, pituitary gland, the infundibulum, which is a little bit superior to the pituitary gland, also called the pituitary stalk, pineal gland, which sits just below the splenium of the corpus callosum. That lights up post-contrast. Petrous matrix, the sinuses. And then these are some pathological structures that enhance post-contrast. And we've talked about some of these in your presentations and in procedures class. Acoustic neuromas, we can find those within IACs. Meningiomas, the meninges surround the brain and the spinal cord. Any other type of tumor, infarcts. So we have a stroke, that will light up post-contrast. Active MS lesions. AIDS, abscess, scar tissue post-discectomy. So contrast helps differentiate between a reoccurring herniation versus just scar tissue. So giving the example of Kim, because she's recently gone through this, she had, surgery to repair a herniated disc. She still had back pain, went back, got an MRI, and they were trying to distinguish between, did she have just scar tissue from her first surgery that was causing the pain and then the impingement on the cord, or did the rest of that disc material that still was in her spine, did that herniate again? And unfortunately, she had a re-herniation of the disc material that was still there, that they did not remove. So that helps distinguish that in the lumbar spine mainly, and bone mets. So multiple myeloma, but mostly it's patients with lung cancer or breast cancer that they know about, and they're trying to distinguish if that cancer has metastasized to the brain. So here's an example of brain mets. So usually they're very small, enhancing lesions, and there's no rhyme or reason to how they look. They're just kind of all scattered throughout the brain. And the patient treatment and management changes according to the number of lesions they detect. But this is always a bad sign. And usually patients that have like breast cancer that they know about get like a yearly brain MRI just to see if anything's metastasizing. Here's another example of the brain mets. axial T1, coronal T1. These are not fat-setted images. And remember, usually most images post-contrast are fat-setted to increase our contrast to noise ratio. The spine, we're looking for syrinx, multiple sclerosis lesions, abscesses, any metastatic bone lesions, and then the scar tissue versus the reherniation of the disc material. We already talked about that. When it comes to body imaging, you're really trying to distinguish whether you have a malignant lesion within the liver or a benign lesion. Most malignant lesions within the liver are arterial fed, so they're going to highlight on that first pass of contrast. And the benign lesions are normally venous fed, so they're going to highlight on the second pass of contrast. So that's why it's so important to make sure you catch, when you're doing the abdomen imaging, catch the contrast at the appropriate time so that you get the arterial phase, you get the venous phase, and then you get the delayed phase, which is basically the equilibrium phase. Everything has washed out at that point. But the radiologist is able to determine by those three different phases whether a lesion is metastatic versus benign sometimes. So this is malignant lesions only be demonstrated on the first pass after injection. So this is a good slide to kind of show you the different phases. Great. Blow this up a little bit. But this is early arterial phase. So you should see the kidneys enhancing, just the outer portion of the kidney enhancing the contrast near the cortex. Not really the renal pelvis in the middle, but just the renal cortex enhancing with contrast. And your spleen should have a mottled appearance. And then you can see here your pancreas is starting to enhance too. So this is your early arterial phase. This is what it should look like on that first pass. This is if you delayed in any way, if you accidentally missed the appropriate time and you hit start your contrast, or basically you hit start your sequence a little too late, this is what it's going to look like. It's the late arterial phase. And you can see here that we're starting to get a little bit of contrast in that portal vein here coming up into the liver. So we do not want this because the radiologist is not going to get a true assessment of the arterial phase. Here is that venous phase, the second pass. This is what it should look like. So now we have more contrast completely in the kidney. We don't have a mottled appearance of the spleen, and then our liver is starting to enhance with contrast. And then your delayed phase, pretty much every organ in the abdomen has contrast in it. Okay. So those are your three phases, and arterial should look like this, venous phase, and then your delayed imaging. So you can see the tumor right here did not enhance on the venous phase, so this is most likely a malignant lesion within the liver. And then they also has a transitional phase, and then your hepatobiliary phase. This is for the eovist, watching the contrast be eliminated by the biliary system. So we look at the liver, but we also look at all the arterial structures within the abdomen. So if your patient has a abdominal aneurysm, a AAA, they could be looking at that. Any type of dissection they could be looking at for your contrast enhanced MRAs. So in conclusion, gadolinium has improved visualization of lesions by increasing the contrast between normal tissue and that actual lesion. So that tiny metastatic brain lesion that we were not able to see on the pre-contrast T1 weighted image, now we can see because it is brighter and we can distinguish it between our normal brain tissue. Our scan time does increase anytime we're using gadolinium, so just be mindful that when you're talking to your patient, they'll say, oh, this is a brain scan, that usually only takes 20 minutes. Well, maybe the last one you did was without contrast, you're going to add about 5 to 10 minutes just because we're going to be injecting contrast. If you have a difficult stick, I highly recommend getting an IV started before you get them on the table because you don't want to be fooling around with trying to get IV access halfway through the scan. Okay, so if they say they're a difficult stick, try and get the access before you get them on the table because if you're trying to, if you pull them out, you finished all the pre-contrast sequences, you pull them out, and then you can't really get IV access. You've already scanned and you set up your localizer scans and everything's set up. You would basically have to reposition them and do one more or at least a localizer scan if you got them off the table. So if they are a difficult stick, usually start the IV before you get them on the table. Be aware of your contrast dosage. What's the appropriate amount of dosage for gadolinium?
ml per pound. If
Which,
you're 150, you get like 15.
okay, so that's like the common conversion we usually look for, but what's the actual per kilogram? Because that's going to be on the registry.
10,
Because that's a good quick conversion, but you need to know the registry conversion.
It's 0.2 moles per. 0.1 millimoles per kilogram.
Good. 0.1 millimoles per kilogram. And that, Lily, usually equates to 1 cc per 10 pounds. All right, so what are some structures that normally enhance with contrast? Just name 3. Normally enhance. There's no pathology, but they're going to enhance.
The pineal.
Pineal gland is one. Pituitary. And what? Infundibular, more pituitary stuff. Choroid plexus, another one. Which agent has higher relaxivity, Dotarim or Multi-Hands? Multi-Hands. Going to appear brighter at the same amount of dose. If you inject the patient with 10 cc's of both contrast agents, Multi-Hands is going to appear brighter, more hyper intense on your T1 weighted image. Which one's more stable, Dotarim or Multi-Hands? Dotarim, because it is macrocyclic, it's cage-like, it wraps completely around the gadolinium ion, and it's ionic. All right. So I have the 3 articles that I told you guys to read. And I'm going to divide you guys into 3 groups. We're going to read over the article if you didn't get a chance to read over it. And then once your group has discussed it, we're going to divide up or switch groups so that each article is represented within a group. Okay? So then you're going to compare the articles to each other, just in a discussion. And then I'm going to help with what I call a synthesis matrix, which helps kind of organize these articles in your thought process, because it will help when it comes to writing your paper. I use a synthesis matrix to compare all the articles that I find when I'm writing like a research paper, So I'm going to kind of show you how that's done. So it might be beneficial for you guys because I know you have your research papers coming up next semester, but you have your outline is due coming up, right?
What's,
Wednesday. Your outline's due when? It's
oh,
what's
everything
Wednesday
is
right now?
Wednesday.
Next Wednesday, right?
Next Wednesday.
Okay.
Oh,
was pushed.
And you have to have how many articles cited?
At least 8.
At least 8. Just the outline, right? And the title. You don't actually have to have any content within each section, right?
So expanded outline.
Expanded outline. Okay. So like just quotes. Quotes. Okay. Alright. So I'll help kind of navigate that whole situation, but first read over just one of the articles and then we'll pair up and we'll discuss it. Okay?
This is ridiculous. What is all that plastic sign on this? Yeah.
It's little, you printed yours out already, right?
Budget.
Yeah.
That's fine.
What's wrong with that?
Yeah.
we need to read this one.
Yeah, just read that.
No, I mean,
So take just 15 minutes to look over it.
actually use one of the ones, things that one.
You already
The
read that?
previous project, yeah.
Oh, okay.
For Farmer College.
Oh, really?
Yeah, actually, I started reading, I was like, this looks familiar.
Alright, so I'm going to pause the video while the students read those articles.